Assalamu alaikum. Dear students, today we are going to discuss a very important topic, that is ECG recording and basic interpretation. ECG recording is a very useful tool for the physicians and cardiologists because it looks directly into the heart, it is easily available, and the importance of this cannot be undermined in cardiology.
It is non-invasive, and not only that, cardiologists are using it. You as an emergency physician, you can have many insights like electrolyte imbalances, hyperkalemia. So this is all not only for the cardiology, this is also very important in acute medicine.
So what does ECG stands for? Basically it's electrocardiogram. In UK it's also called EKG, so electrocardiogram. Who first invented ECG? Who first described myocardial infarction on ECG? So these are the questions that we are going to answer in the coming slides. So what is an electrode, positive deflection, negative deflection, waves, and how to interpret ECG? That is our main backbone of the lecture. So these are the things that we'll discuss. We'll discuss all these ECGs. For now, you will be looking at random lines, but at the end of this lecture, these will be meaningful to you. So this is the conduction system of the heart. It starts from the SA node. There are three atrial pathways that all converge onto the AV node. Then there is this very small bundle of His, and from the bundle of His there are two fascicle arises, left fascicle and the right fascicle, and the left fascicle is further divided into left anterior and left posterior fasciculus, and ultimately these fasciculi end up in Purkinje fibers, which supplies the ventricular wall. So this is the electrical system of the heart, and here you can see the diagrammatic representation of these conduction pathways. This is SA node, these are the three atrial pathways. This is the AV node, bundle of His. Here you can see the right and left fascicles, and left fascicle is further divided into anterior and posterior fascicle, and these are the Purkinje fibers. Here again a diagrammatic representation of conduction system of the heart. So P wave, ECG consists of waves. As you have already read in Guyton, what these waves stand for. So P, Q, R, S, T. These are the waves. Sometimes there is an additional wave called U wave. So P wave basically arises because of the atrial depolarization. Okay, and PR interval depicts the time taken from for the electrical conductivity from the SA node to the AV node. If so, this is the diagrammatic representation of ECG. This is the P wave. From the start of the P wave to the start of the Q wave is called PR interval. The first negative deflection is the Q wave. The first positive deflection is the R wave.
याद रखो कि Q की definition बहुत important है. This is the first negative deflection. If you don't find a first negative deflection, then Q wave is absent. Supposedly if this goes straight like up, then there would be no Q wave. Okay, so Q wave, remember it is the first negative deflection in the QRS complex. If there is no negative deflection in the first negative deflection, then Q is absent. तो इस बात को हमेशा बेटा ज़हन के अंदर रखना. सपोजेडली एक पेशेंट है, उसमें पहले एक छोटी सी आर आ गई है, स्मॉल राइज इन आर, एंड देन देयर इज़ अ नेगेटिव डिफ्लेक्शन. तो दैट इज़ नॉट क्यू, दैट इज़ एस वेव. And sometimes you have got two negative deflections which are not the first ones, then they are S1 and S2. So Q is the only first negative deflection. इस बात को अपने भूलना नहीं है, ठीक है बेटा.
So first positive deflection is the R wave. This second negative deflection is basically the S wave, and from this point to start of the T wave, this is called the ST segment. Okay. So this is PR interval and this is ST segment, and this is the T wave.
ST segment है, ST segment is followed by a T wave. ये जो ST segment है बेटा, इसकी बहुत इम्पोर्टेंस है. ये ऊपर चली जाए या नीचे चली जाए. So if it goes up, this is known as elevated. If it goes down, this is known as depressed ST segment. Now this is very important. We refer you back for the lecture of acute coronary syndrome, in which full details of the current guidelines are available of ST depression and elevation. Now the question arises is, Dr. Zahid, do give them a clear concept from which reference we are going to see whether this is a depressed isoelectric or elevated ST segment.
So the isoelectric line of the heart is basically TP segment. This line which connects the T wave to the next P wave is called the TP segment, and it is the isoelectric line of the heart.
So बेटा आपने यहाँ से एक लाइन, मतलब you can use the ruler, foot or a piece of paper and to see कि ये लाइन इसके बराबर है या नहीं है. तो इसके बराबर है, so this is isoelectric. अगर ये लाइन इससे नीचे होती तो फिर this was a depressed, और अगर ये लाइन in reference to the TP segment ये अगर elevated होती तो फिर this was elevated. So याद रखो isoelectric line of the heart कौन सी है? TP segment.
So let's go back to our waves. PR interval basically depicts the conduction through the AV node and the bundle of His. और जब ये इंटरवल जब AV नोड में या बंडल ऑफ हिस में प्रॉब्लम आएगी तो PR इंटरवल प्रोलॉन्ग हो जाएगा. QRS complex basically is the depolarization of the ventricles. A Q wave is any negative deflection at the beginning of a QRS complex. So the first negative deflection. Small Q waves in some leads may be normal, large Q waves are pathological.
So you need.
So the R wave is the first positive deflection, S wave is the negative deflection, immediately following in R wave, QRS complex. जो QRS complex है ये तीन waves पे मुश्तमिल होता है, Q, R and S, और इसकी duration बहुत important है, it's less than 120 milliseconds. So ST segment we have already explained, TP segment is the isoelectric line, ये change नहीं होता. हम ST segment को elevation या depression TP segment को reference लेके देखते हैं. And T wave is basically the repolarization of the ventricles. This is Einthoven's triangle. जब पहली मरतबा आइंथोवन ने ECG डिस्कवर की थी, इजाद की थी, तो उसने जो लीड्स लगाई थी उनको देखते हुए आइंथोवन्स ट्रायंगल का कॉन्सेप्ट आया था. सो तीन लीड्स हैं बेसिकली जो पहली मरतबा लगाई गई थी. लीड 1 जिसमें नेगेटिव इलेक्ट्रोड जो है ये राइट आर्म पे होगा और पॉजिटिव इलेक्ट्रोड लेफ्ट आर्म पे होगा. लीड 2 जिसमें नेगेटिव इलेक्ट्रोड जो है ये लेफ्ट आर्म पे होता है और पॉजिटिव इलेक्ट्रोड जो है ये लेफ्ट लेग पे होता है. और लीड 3 जिसमें पॉजिटिव इलेक्ट्रोड जो है ये लेफ्ट आर्म पे होगा और नेगेटिव इलेक्ट्रोड एंड पॉजिटिव इलेक्ट्रोड इज ऑन द लेफ्ट लेग. So these are the three leads. The lead is basically two electrodes. One is the negative one and the other one is the positive one, and then there is a ground to curb any extra electrical activity, and this lead is used to measure the electrical activity of the heart in a graphical form through a machine. So this is how lead 2 is looking at the heart. So all leads are looking at the heart from different angles. So then there are the other leads, AVR, AVL and AVF. These are called the augmented leads, in which the negative electrode is incorporated into the machine and there is just the positive electrode on the lens. Okay. So So these are the chest leads. There are 6 chest leads, V1, 2, 3, 4, 5 and 6. And these leads are applied on the precordium. The V1 is applied in 4th intercostal space on the right sternal border. The V2 is applied on the 4th intercostal space alongside left sternal border. V4 is in mid clavicular line, and between V2 and V3 is placed V4 is placed V3. The V5 is in anterior axillary line, and V6 is placed in mid axillary line in 5th intercostal space. So this is how you apply these leads. You can study the placement of these leads from this table. So there is a very simple mnemonic: read your good book. A red electrode is applied on the right upper limb. The yellow electrode is applied on the left upper limb. The green electrode is applied on the left lower limb, and the black electrode is applied on the right lower limb. So this is how you are going to place the limb leads. This black electrode is the neutral electrode. It is used as the ground, while these are the active electrodes. This is the color coding of the chest leads. The V1 is red, V2 is yellow, V3 is green, V4 is brown, V5 is black, and V6 is purple. So this is how you will identify these leads on an actual machine. So these are the leads that are looking at different walls of the heart. Lead 2, 3 and AVF is looking at the inferior wall of the heart. Lead 1, AVL is looking at the lateral wall of the heart. Lead V5 and V6 are also looking at the lateral wall of the heart. So 1, AVL, V5 and V6 are the lateral leads. So lead V3, V4 is looking at the anterior wall of the heart. Lead V1 and V2 are the septal leads. So these are looking at the septum. So V1, 2, 3 and 4, these are the anteroseptal leads. So ECG is a very standardized graphic paper on which there is graphical drawing of the electrocardiogram of a patient. So the paper is running at a speed of 20 to 25 mm per second. One small box on this graphical paper is of 1 mm and it is equal to 0.04 seconds. One large box consists of 5 small boxes and it is of 5 mm duration, and it equals to 0.2 seconds. So 1 second on an x-axis of ECG is 5 large boxes, and one small box along the y-axis is shows the voltage of the wave, and one small box is equal to 0.1 millivolt, one large box is equal to 0.5 millivolts, and 2 large boxes are equal to 1 millivolt. Remember, these the speed of the ECG can be changed, the voltage of the ECG can be changed. So always look for standardization marks on an electrocardiographic paper, and these will tell you how to interpret the ECG. So we'll try to understand what is standardization of the ECG. So this is a standard ECG, this is the small box, this is the large box. The bold lines are indicating the large box. And this large box consists of 5 small squares along x-axis and 5 small squares along y-axis. So one small box equals to 0.04 second and one large box equals to 0.2 seconds. And along the y-axis you can see one small box equals to 0.1 millivolt and 5 small boxes, that is one big box, equals to 0.5 millivolts. So this is the standardization of ECG. This is the ECG paper, and you can see there are multiple large boxes and small boxes along the x-axis and y-axis. So these are the 6 headings under which we interpret an ECG. The first thing is whether the heart rate is regular or irregular. So we will look for RR interval and we'll calculate the rate of the heart. So in order to calculate the rate of the heart, you divide the 300 divided by number of large boxes between 2 consecutive R waves. There is another formula. You divide 1500 divided by number of small boxes between 2 consecutive R waves. Or there is the third formula, which is used for irregular heartbeats. Count the number of cardiac cycles in 10 seconds, and that is 50 large boxes, and multiply these by 6. So you will get the heart rate of an ECG with an irregular rhythm. So bradycardia is when heart rate is less than 60 beats per minute, and tachycardia is when the heart rate is greater than 100 beats per minute. So this is an activity for you. Calculate the number of boxes, large boxes between these 2 R waves. Let's see, 1, 2, 3, 4 and 5. So these are the 5 boxes. Divide these 300 by 5. So the answer will be 60. So 60 is your heart rate for this ECG. So look at this ECG. You can see the rhythm is not regular in this ECG. Here you can see the interval is greater than the next RR wave. So rhythm is irregular. So what you will do, first you will count 50 large boxes. Let's count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 1, 31, 2, 3, 4, 5, 6, 7, 8, 9, 10, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50. So from here to here there are 50 boxes. Now count the number of R waves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. So there are 21 R waves in 50 large boxes. Now multiply this 21 with 6 and you will get heart rate in 60 seconds. That will be your heart rate of this ECG. So 21 multiplied by 6 is 126. So 126 is the heart rate for this ECG. is the normal rhythm. If the rhythm is irregular, there are two kind of rhythms: regularly irregular and irregularly irregular. The next thing is the axis. There is the normal axis, there is the left or right axis deviation. So the normal axis is usually 60 degree, but it ranges from 0 degree to 120 degree. When you're going to measure the axis on an ECG, you'll find that 1, 2, and 3 leads. All the QRS complexes are upright. In right axis deviation, the QRS complex in lead 1 is downright, and in lead 2 and 3 it is upright. So this is right axis deviation. And in left axis deviation, the QRS complex in lead 1 is upright, and it is in lead 2 and 3 it is predominantly downright. So this is how you measure the axis deviation on an ECG. There is another method. Um, if in lead 1 and AVF QRS complexes are upright, this is normal axis. If in lead 1 it is down and in lead AVF it is up, it is right axis deviation. And if in lead 1 it is upright and in lead AVF it is downright, it is left axis deviation. And if both of these axes are downright, then it is extreme left axis deviation. In this ECG, you can see that lead 1 is upright and lead 2 and 3 are downright. So this is indicating a left axis deviation. So here in this ECG, you can see that lead 1 is predominantly downright and lead 2 and 3 are upright. So this ECG is of right axis deviation. So if we apply regarding ischemia and infarction, these four parameters are usually used. T-wave inversions indicate the presence of ischemia, and these can be present during ischemia, or these can be a non-specific finding of ischemia. ST segment depression, ST segment elevation, and the presence of Q waves. These all indicates the presence of ischemia and infarction on an ECG. So these are the Q waves. As we have told you, the first negative deflection is called Q wave. And here you can see that this Q wave is more than 3 mm, or it's more than 1/3 of the height of R wave. So this is the definition of pathological Q wave. So here you can see ST segment elevation. Look at this TP segment. This is the TP segment and this is the ST segment, and both these are on the same line. So here the ST segment is normal, but here look at this. This is the TP segment and this is the ST segment, and ST segment is well elevated above the TP segment. So this is ST segment elevation. And here, after a few hours of this acute MI, you can see now Q waves has started forming, and this R wave height is also decreasing. R wave height decrease होने का मतलब है मायोकार्डियम का मास कम हो रहा है, और Q wave का मतलब है कि नेक्रोज्ड एरिया को शो करती है. और कुछ जब 1 या 2 दिन गुजरते हैं तो T wave इन्वर्जन ऑफ द टी वेव होनी शुरू हो जाती है, और क्यू वेव की जो डेप्थ है वो बढ़ जाती है, और कुछ दिनों के बाद क्यू वेव एस्टैब्लिश हो जाती है, एसटी सेगमेंट अपनी नॉर्मल हालत में आ जाता है, टी वेव की इन्वर्जन परसिस्ट कर सकती है, and ultimately the T wave inversions can also disappear, and the final evidence of an old infarction is the presence of Q waves after a few weeks later. So ये जो Q waves pathological Q waves बाकी रह जाती हैं, ये हमें old MI को शो करती हैं.
So just concentrate here. Is there a Q wave here? No, this is a QRS complex without a Q wave. So this is RS. And is a Q wave here? No, this is a QRS complex which is not having a Q wave. So this is an RS complex. So Q wave is the first negative deflection. So it's increasing here, 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 here. So Q याद रखो कि is the first negative deflection.
So here, let's see this ECG. You can see this is the TP segment. This is the TP segment, and this is the ST segment. And you can see ST segment is elevated in lead 1. Let's go to the other leads. Here, there is a slight ST segment depression as compared to the ST segment. And here again, ST segment depression is present. In AVL, ST segment elevation is present, okay, and here in lead, in cardiac leads, ST segment elevation, 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 elevation. So these all
So
indicate.
whenever we say this is elevated, we are talking about from the reference of TP segment. So TP segment के हिसाब से हमने देखना है कि this is ये ऊंची है, so this is elevated. So always look for the TP segment because that is your isoelectric point. TP segment is your isoelectric point. So इस लाइन से ये देखें आपके कितना ज़्यादा एलिवेटेड.
सो बच्चों, अब आपने ये देखना है कि ये चेंजेस किन किन लीड्स में प्रेजेंट हैं. मैंने आपको बताया था 1, AVL, V5, V6 ये लेटरल लीड्स होती हैं. सो 1 के अंदर भी एलिवेशन आ गई, AVL के अंदर भी एलिवेशन आ गई, V5 और V6 के अंदर एलिवेशन आ गई. मतलब लेटरल वॉल ST एलिवेशन MI है. अब अगर आप ये देखें कि लीड 1, 2, 3 और 4 के अंदर भी चेंजेस हैं, तो ये लीड 1 और V1 और V2 जो हैं ये सेप्टल लीड्स हैं, V3 और V4 जो हैं ये एंटीरियर लीड्स हैं. मतलब अंट्रोसेप्टल वॉल का भी ST एलिवेशन MI है. सो दिस इज अंट्रोसेप्टल एंड लेटरल वॉल ST सेगमेंट एलिवेशन MI. और ये जो लीड्स 2, 3 और AVF के अंदर आपको ST सेगमेंट डिप्रेशन नजर आ रहा है, इट इंडिकेट्स रेसिप्रोकल चेंजेस. ये डिस्टेंट इस्कीमिया को शो करते हैं. सो लेट्स हैव अ लुक एट दिस ECG. आप ये देखें लीड 1 के अंदर आपको क्या नजर आ रहा है. दिस इज TP सेगमेंट एंड दिस इज द ST सेगमेंट, और यहाँ पर आपको ST सेगमेंट डिप्रेशन भी नजर आ रही है. लीड 2 के अंदर लीड क्या है, ST सेगमेंट एलिवेशन है. ये TP सेगमेंट है, ये ST सेगमेंट है, और ST सेगमेंट एलिवेटेड है. इसी तरह लीड 3 के अंदर भी ST सेगमेंट एलिवेशन है. AVR, दिस इज AVL, AVL के अंदर ST सेगमेंट डिप्रेशन है. AVF के अंदर ST सेगमेंट एलिवेशन है. इसी तरह से अगर आप इन लीड्स को देखें, डिप्रेशन, 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 एंड हेयर देयर इज अगेन डिप्रेशन V5 और V6 के अंदर. तो अगर आप देखें कि लीड 2, 3 और AVF के अंदर ST सेगमेंट एलिवेशन है. लीड 2, 3 और AVF जो है ये इंफीरियर वॉल ऑफ द हार्ट को शो करती है. मतलब ये इंफीरियर वॉल ST सेगमेंट एलिवेशन MI है. और ये जो बाकी वॉल के अंदर लीड्स के अंदर आपको ST सेगमेंट डिप्रेशन नजर आ रहा है, ये डिस्टेंट इस्कीमिया की चेंजेस हैं. मतलब लेटरल वॉल और एंट्रोसेप्टल वॉल का डिस्टेंट इस्कीमिया भी चल रहा है इस पे. सो दिस इज एन ECG ऑफ इंफीरियर वॉल ST सेगमेंट एलिवेशन MI. So this is the ECG where you can see कि आपको एक तो वॉल शो की गई है कि कौन सी लीड किस वॉल को शो करती है, और उस कौन सी आर्टरी ब्लॉक होने से उस वॉल का इस्कीमिया होगा.
सो बेटा सबसे पहले आप लोग देखो कि ये ब्राउन कलर्स हैं, दे आर ऑन V5, V6 और 1 and AVL. So this would be
lateral wall, and the artery block will be circumflex artery.
ठीक है. So lateral wall artery is
Circumflex artery.
and then you have got the inferior leads 2, 3 and AVF.
And the artery block will be right coronary artery.
So inferior wall MI 2, 3 AVF,
lateral
and
wall MI 1 AVL V5 V6.
and if it is inferior wall MI, then this is lead
Right coronary
2,
artery.
cursor ले ना, 2,
Lead 2 3
3 and
AVF.
AVF. And now coming to the left
Anteroseptal leads.
anteroseptal leaves, they are V1,
V1,
2.
V2 are septal leads, and V3 and V4 are anterior leads. So these four leads are anteroseptal wall leads. And
So
the artery
1
block,
and 2 are septal, and 3 and 4 are anterior. And the artery block is, सबसे जो important artery है वो है
left anterior descending artery. So the next parameter we are going to have a look at is the blocks. कि कोई block तो नहीं मौजूद. So there are basically three blocks: first degree, second degree, and third degree heart block. इसके अलावा left bundle branch block होता है और right bundle branch block होता है. Left bundle branch block के आगे दो सब types हो सकती हैं: left anterior hemi block, left posterior hemi block, and complete left bundle branch block. So हम इन blocks को देखेंगे. So this is an ECG of first degree heart block. First degree heart block में क्या होता
बेटा
है?
आपको सबसे पहले ना जस्ट हैव अ लुक एट दिस ECG और देखें कि कोई आपको एबनॉर्मेलिटी नज़र आ रही है एंड जस्ट कंसंट्रेट ऑन द PR इंटरवल.
So आपको बताया था कि PR इंटरवल जहां से P वेव शुरू होगी, जहां से ये पॉजिटिव डिफ्लेक्शन आना शुरू, वहां से स्टार्ट होता है. तो आपने यहां से देखना है, यहां से लेके Q वेव स्टार्ट होने तक या QRS कम्प्लेक्स स्टार्ट होने तक PR इंटरवल है. ये PR इंटरवल 5 स्मॉल बॉक्सेस से कम होना चाहिए. अगर ये 5 स्मॉल बॉक्सेस से ज्यादा हो जाए तो इसका मतलब है PR इंटरवल प्रोलॉन्ग है, और ये जो प्रोलॉन्गेशन है इट विल इंडिकेट फर्स्ट डिग्री हार्ट ब्लॉक.
सो इसमें आप कैलकुलेट करिए और देखें कि कितने स्मॉल ब्लॉक्स चल रहे हैं.
तो ये जो एक बड़ा बॉक्स है, बिग बॉक्स, इट इज इक्वल टू 5 स्मॉल बॉक्सेस.
सो
एंड
5 तो सीधे सीधे इधर हो गए क्योंकि ये बॉक्स आपको नजर आ रहा है कि ये सारा इसको क्रॉस हुआ है और प्लस देयर इज अनदर स्मॉल बॉक्स आल्सो एडेड.
so this is prolongation of the PR interval is actually the first degree heart block, and it indicates that SA नोड से लेके AV नोड तक जो डिपोलराइजेशन आ रही है, जो इलेक्ट्रिकल एक्टिविटी आ रही है, वो किसी वजह से डिले हो रही है. So here you can have a good look at the number of boxes. यहाँ से लेके यहाँ तक आप इसको कैलकुलेट करेंगे. ये जो बड़ा बॉक्स है ये 5 स्मॉल बॉक्सेस हैं, 1 2 and 3. तो 5 + 3 8 स्मॉल बॉक्सेस के बराबर PR इंटरवल है. तो ये प्रोलॉन्ग है. Causes of first degree heart block, it can be because of the drugs, beta blockers, calcium channel blockers. ये दोनों हार्ट रेट को कम करने वाली ड्रग्स हैं. इस तरह डिजिटैलिस भी हार्ट रेट को कम करती है, इलेक्ट्रिकल एक्टिविटी को स्लो कर देती है, जिसकी वजह से PR इंटरवल बढ़ता है. वैगल टोन अगर किसी वजह से बढ़ जाए, जैसे कैरोटिड, ये जो बल्ब है नेक के अंदर, इसको अगर कोई मसाज करे तो वैगल टोन बढ़ जाती है. inferior wall ischemia में बढ़ जाती है because the right coronary artery is responsible for supplying the SA node. तो उसमें फर्स्ट डिग्री हार्ट ब्लॉक आ सकता है. फर्स्ट डिग्री हार्ट ब्लॉक अगर किसी के आ रहा हो तो उसको किसी ट्रीटमेंट की ज़रूरत नहीं होती, उसे सिर्फ मॉनिटर करते हैं. ठीक है. और अगर किसी वजह से ब्रेडिकार्डिया बहुत ज़्यादा हो जाए तो आप एट्रोपिन यूज़ कर सकते हैं.
और इसमें बेटा ये बात इम्पोर्टेंट है कि ट्रीटमेंट की ज़रूरत नहीं, बट इफ़ इट बिकॉज ऑफ द ड्रग्स, तो फिर आपके वो ड्रग्स की डोज को रीशेड्यूल करना है.
सो दिस इज सेकेंड डिग्री हार्ट ब्लॉक. सेकेंड डिग्री हार्ट ब्लॉक की दो किस्में होती हैं, टाइप 1 एंड टाइप 2. इसको कहते हैं मोबिट्स टाइप 1 और मोबिट्स टाइप 2. ठीक है. तो जो ये सेकेंड डिग्री हार्ट ब्लॉक टाइप 1 है, आप इस ECG को देखें और आपको पता चलेगा कि इसमें कोई अबनॉर्मेलिटी है कि नहीं. अच्छा बच्चों, एक कॉन्सेप्ट आपको यहाँ पर इंट्रोड्यूस कर दूं कि जब भी हम रिदम को देखने लगते हैं तो हमें एक लीड चाहिए होती है जिसे हम रिदम लीड कहते हैं. रिदम लीड यूजुअली लीड 2 होती है. ठीक ठीक है, क्योंकि इसके अंदर हमें पी वेव बहुत अच्छी नज़र आती है। इसके अलावा लीड V1 के अंदर भी हमें पी वेव बहुत अच्छी नज़र आती है। यूजुअली हम लीड 2 को रिदम लीड के तौर पे लेते हैं, और अक्सर ECGs का ये जो बिल्कुल नीचे वाला चैनल होता है ये रिदम लीड के तौर पे यूज़ होता है। लेकिन अगर ये नीचे वाला चैनल मौजूद ना हो तो आप अलग से रिदम लीड, सिंगल चैनल ECG जैसे होती है, ये 4 चैनल ECG है, तो सिंगल चैनल ECG हो तो उसमें रिदम लीड को अलग से लेना पड़ता है, जिसमें एटलीस्ट कोई 60-70 के करीब बिग बॉक्सेस मौजूद होने चाहिए। तो आप ये ज़रा रिदम लीड के ऊपर गौर करें और देखें कि क्या इसके अंदर कोई नॉर्मेलिटी मौजूद है। चलिए मैं आपको बताता हूँ। इस PR इंटरवल पे गौर करें, ये PR इंटरवल कैसा है, उसके बाद ये PR इंटरवल कैसा है, उसके बाद ये PR इंटरवल कैसा है, एंड देन here the QRS complex is here the QRS complex is missing। यहाँ पर एक QRS complex आना चाहिए। तो ये देखें कि प्रोग्रेसिवली PR इंटरवल बढ़ता जा रहा है and ultimately there is a missing QRS complex and then again the process repeats। तो हर 3-4 QRS complexes के बाद जब PR इंटरवल एक खास हद से बढ़ता है तो उससे अगली बीट जो है वो कंडक्ट नहीं हो पाती, और वो कंडक्ट ना होने की वजह से एक मिसिंग QRS complex आता है। इसको हम कहते हैं टाइप 1 सेकेंड डिग्री हार्ट ब्लॉक। So here you can appreciate in this magnified view, most commonly due to intranodal pathology। किसी वजह से AV नोड का इस्कीमिया हो जाए या उसके ऊपर कोई ड्रग्स एक्ट करती हों तो उसकी वजह से ये टाइप 1 सेकेंड डिग्री हार्ट ब्लॉक आएगा। No treatment is required until the patient is symptomatic। Atropine can be used to treat bradycardia। If there is an offending drug, you have to decrease the dosage of that drug or you have to stop that drug।
अब जहाँ पे हम लोग लिख रहे हैं ना कि नो ट्रीटमेंट इज रिक्वायर्ड, इसका ये मतलब नहीं है कि आपको इस्कीमिया की वजह से ये चीज़ हो रही है तो हमने इस्कीमिया को ट्रीट नहीं करना। जो भी ऑफेंडिंग कॉज है उसको ट्रीट करना है।
So this is type 2 second degree heart block। You can see that there is a P followed by a QRS complex, and again there is a P followed by a QRS complex, there is a P followed by a QRS complex, and then there is a P which is not followed by a QRS complex। Okay, here the QRS complex is missing, and similar process that repeats again। This P is followed by a QRS complex, there will be 2 more such complexes, and there will be a P again which is not followed by a QRS complex like you can see over here। So this is a type 2 second degree heart block के कुछ QRS complexes आएंगे जिनमें P के बाद QRS complex होगा, और फिर एक P आएगी जिसके बाद QRS complex नहीं होगा। The electrical activity is failed to conduct from AV node to the ventricles। P बनेगी, QRS complex नहीं बनेगा। This is type 2 second degree heart block। This is commonly due to infranodal pathology। It is a higher form of heart block, so you may need to temporary insert a temporary pacemaker, or sometimes a permanent pacemaker as well, and there is a very high chance that it can progress to higher form of block like trifascicular block or complete heart block। So you need to have a very close observation on these patients। So this is complete degree heart block। In complete heart block, atria and ventricle, there is complete dissociation of atria from the ventricles। atria अपने रेट पे बीट करता है और ventricle अपने रेट पे बीट करता है। एट्रिया का पेसमेकर जो है इस केस के अंदर ऐसे नोड होता है, ठीक है, तो एट्रिया की जो रेट होता है वो ज़्यादा होता है। हेयर यू कैन सी दिस इज द पी वेव, दिस इज पी वेव, ओके, एंड अगेन दिस इज पी वेव, और ये आप देख रहे हैं कि एक ही जगह पे 2 पी वेव इकट्ठी आ गई हैं, तो
एट्रियल रेट इज,
तो एट्रियल रेट आप यहाँ से डिटरमिन कर सकते हैं और P से P के दरमियान का इंटरवल कांस्टेंट होगा। इसी तरह क्यूरस कम्प्लेक्स जो है वो अपने वेंट्रिकल अपने रेट पे बीट करते हैं। उनका पेसमेकर एवी नोड से नीचे कोई जगह होती है। आपको मालूम है कि जैसे जैसे हम हार्ट में नीचे आते जाते हैं तो जो हमारे पेसमेकर्स होते हैं, सेकेंडरी पेसमेकर्स, एक्टोपिक पेसमेकर्स, उनका रेट कम होता है। तो क्यूरस कम्प्लेक्स का रेट जो है ये पी वेव की निस्बत से कम होगा, लेकिन पी टू पी डिस्टेंस सेम रहेगा, क्यू आर एस डिस्टेंस सेम रहेगा, ठीक है। लेकिन इन दोनों का आपस में कोई ताल्लुक नहीं होगा। सो दिस इज व्हाट हैपन्स इन कंप्लीट हार्ट ब्लॉक। और आप इसमें एक और बात भी देख सकते हैं कि क्यूआरएस कॉम्प्लेक्स इज a bit widened. It is because of the location of pacemaker below the AV node, जिसकी वजह से क्यूरस कम्प्लेक्स की थोड़ी सी वाइडनिंग हो जाती है। सो दिस इज कंप्लीट हार्ट ब्लॉक। So atrioventricular conduction block treatment, a temporary or permanent pacemaker is the definite treatment. इसके अलावा जो भी ऑफेंडिंग इसमें पैथोलॉजी होगी, जैसे इलेक्ट्रोलाइट इम्बैलेंस है, हाइपरकैलेमिया के अंदर हो जाता है, इस्कीमिया के साथ हो जाता है। हाइपरकैलेमिया का इलाज करें, इस्कीमिया का करें। वोगल टोन अगर किसी वजह से इंक्रीज है उसको करते हैं। अगर कोई ड्रग ब्लॉक कर रही है, जैसे बीटा ब्लॉकर है, कैल्शियम चैनल ब्लॉकर है, उसको स्टॉप कर दें। एंड एडजंक्टिव फार्माकोलॉजिकल ट्रीटमेंट कैन बी यूज, जैसे एट्रोपिन यूज कर सकते हैं, आइसोप्रोट्रिनॉल यूज कर सकते हैं। ट्रांसक्यूटेनियस पेसिंग इज एन ऑप्शन वेयर एक्सपर्टीज फॉर द इन्वेसिव पेसमेकर इज नॉट अवेलेबल. Temporary transcutaneous pacing is an option. Permanent pacemaker is the definite. This is a guideline summary for pacemaker implantation in acquired AV block. Please have a look at this and remember this by heart. So, remember this guidelines. So right bundle branch block. In right bundle branch block, there is a tall R wave in V1, usually notched with an RSR pattern. There is a prominent delayed and widened S wave in 1, V5 and V6, and QRS complex duration is more than 0.14 seconds. Look at this ECG. So here you can see the RSR pattern. There is a small R wave followed by an S wave and a large R wave. So R, S, R pattern. And there is an upright tall R wave in V1. Usually there is no upright R wave in V1, but here you can see one. The second thing is there is a slurred S wave in V5 and V6. And if you look at the QRS interval, this interval is more than 0.14 seconds. 0.14 seconds mean 3 small squares. So it is more than 3 small squares. So this is right bundle branch block. If you look at left bundle branch block, similar thing is here, widened QRS complex. And there is usually a left axis deviation, but it is not always the case. And there is an M pattern in lead 1, V5 and V6. Now in right bundle branch block, it was predominant in lead V1 and V2, while here it is in lead 1, V5 and V6. And there is ST segment and T waves are opposite to the terminal QRS complex reflection. So let's see. The QRS complex is widened. There is no upright tall R wave. There is an M pattern in lead 1, V5 and V6. And you can see that ST and T waves are oppositely deflected than the corresponding QRS interval. So this is left bundle branch block. Left anterior hemi block, left axis deviation of at least 45 degrees. The presence of a QR complex, small q and a big R complex in lead 1, and there usually a small r and big S complex in lead 2 and 3, sometimes AVF as well. So look here, there is a very small R and a deep S wave in lead 2, 3, and you can see in lead AVF as well. There is a small Q and a large R in lead 1, and there is a left axis deviation as well. So this is left anterior hemi block. Next block is left posterior hemi block. The criteria to diagnose left posterior hemi block is given as under: right axis deviation, presence of a small q and large R complex in lead 3, and a small r and large S complex in lead 1, absence of right atrial enlargement or any right ventricular hypertrophy or enlargement on ECG. There's a prominent S wave in lead 1, and there's a prominent uh, R wave in lead 3 and a right axis deviation. And you can see that there is no evidence of any right atrial or right ventricular hypertrophy. So this constitutes left posterior hemi block. Now coming to the hypertrophy or enlargement of the different chambers of the heart: right ventricular hypertrophy, left ventricular hypertrophy, right atrial hypertrophy, and left atrial hypertrophy. Ventricular hypertrophy. So this is a very simple criteria of left ventricular hypertrophy. आपने करना क्या है कि आपने लीड V1 और V2 को देखना है, और इन दोनों में से किसी एक लीड के अंदर आपने S वेव का मैग्नीट्यूड देखना है, और इस मैग्नीट्यूड को आपने ऐड कर देना है लीड V5 या कर देना है लीड V5 या लीड V6 के R वेव के एम्पलीट्यूड के अंदर. So the magnitude of S wave in V1 or V2 plus magnitude of R wave in V5 or V6 should be more than 35 mm. And this is the voltage criteria, also known as the cornell criteria for left ventricular hypertrophy. This is another criteria. It's a bit difficult one, and it takes into account many non-voltage criterias as well. So अगर QRS complex का amplitude बड़ा हुआ है, it will constitute 3 marks. STT wave abnormalities हैं 3 marks. P wave of left atrial enlargement 3 marks. Left axis deviation 2 marks, and increased ventricular activation time 1 mark. And the total of these scores should be more than 5 or more than 5, and it will constitute the criteria for left ventricular hypertrophy. This is the ECG for left ventricular hypertrophy. You can see that the S wave in lead V1, and this is the R wave in lead V6. And if you count the magnitude, there are 5 large boxes here and 5 large boxes here. So the total of these S wave in lead V1 and R wave in lead V6, the magnitude is 50 mm. So it constitutes the criteria for voltage criteria for left ventricular hypertrophy. Now your assignment is that you apply the second criteria on this ECG and see if it fits the criteria of left ventricular hypertrophy. Ventricular hypertrophy, if there's right axis deviation, there's usually a dominant R wave in V1, and in V1, lead V1, R is more than S wave, and R wave in lead V1 is more than 5 mm. So these constitutes the criteria for right ventricular hypertrophy. And here you can see that there is a large upright R wave in V1. R wave is much larger than the S wave, and it is more than 5 mm in lead V1, and there's a right axis deviation. Looking at lead 1, 2, 3, you can infer that there's a right axis deviation here. So this ECG is that of right ventricular hypertrophy. Left atrial enlargement, wide and notched P wave in standard lead 1, and a prominent delayed terminal deflection of the P wave in lead V1. So let's have a look at the presentation. In lead 2, two types of P wave abnormalities can be seen. Right atrial enlargement is seen as a taller than normal P wave, and left atrial enlargement is seen as a P wave with a notch in it. So here you see this is right atrial enlargement. The P wave is larger in amplitude. It is more than 2 small squares. It is more than 2 mm. So it is called the P pulmonale. And in left atrial enlargement, the P wave, the duration of the P wave is much increased. There is a notched P wave, and it is called the P mitral, left atrial enlargement. And this is seen in lead 2, standard limb lead. This is the P mitral, as seen in lead V1. So there is an initial upward deflection and later followed by a downward deflection. So this is a notched P wave, and it indicates left atrial enlargement in lead V1. Thank you so much for listening.